I'm an anaesthetist based in Leicester. I'm not a coder, is probably the first thing to say. Our usual coding presenter couldn't make this one, so I've stepped in. I'm the UHL, so our trust lead for clinical coding. So I do have a bit of understanding about the world of clinical coding. As this is the idea of these workshops is that we're a bit more informal, a bit more interactive, and allows you to ask questions in a kind of however you want it. And then also cover kind of tips and tricks of how we can get the most out of our coding, make sure the data is accurate. As with lots of my talks, what I'm going to do is I'm going to start with an animation that gives you a basic overview of what clinical coding involves, and then I'll talk you through some of the things that we've done in our hospital and in other hospitals that that we thought that you may need to be aware of. We'll start there. So. Hoping this works. Let me know if you can't hear the sound.
This animation will give an overview of clinical coding in the NHS. Essentially, clinical coding is the way an NHS organisation records information on what care is given to their patients. It is the translation of the patient record into coded data. It is usually done after the patient has been discharged, and there are strict deadlines that need to be adhered to for data submission. So how does clinical coding work? A patient's hospital stay, from the point of admission to discharge, is called a spell. During their stay, a patient may be under the care of different consultants. This may be due to a change in shift, ward, or speciality. The time period under each consultant is called a finished consultant episode, FCE, or episode of care. So a spell can be made up of a single or multiple FCEs. Clinical coders code diagnoses, comorbidities, complications, and any procedures undertaken for each FCE. So how do we get from treatment to coded episode? All care delivered during a patient episode is documented in the patient notes. Once the episode is complete, the notes are sent to clinical coding, where trained clinical coders carefully read through the notes and allocate the appropriate alphanumeric codes. For diagnoses, they use the International Classification of Diseases 10th edition, ICD-10, which comprises over 16,000 codes. And for procedures and operations, the OPCS Classification of Interventions and Procedures version 4.9, which has over 4,000 codes for procedures and operations. The codes are entered in computer software which determines the Healthcare Resource Group, HRG. Most, but not all HRGs have an associated tariff. An example of this: clinical coders are like detectives, investigating all aspects of their journey from start to finish. You begin by reviewing the documentation, physical and/or digital, for the stay. For example, an elderly woman who had a hip operation 2 days ago. From her medical notes, you find out the main condition being treated, any relevant comorbidities, and the procedure performed. Then, utilising the ICD-10 and OPCS procedure classifications, you find and assign the special alphanumeric codes and record these into the organisation's patient administration system. This coded data can be understood throughout the NHS and beyond, and used to plan for future patient care. What are Healthcare Resource Groups, or HRGs? A Healthcare Resource Group, HRG, is a grouping of diagnoses and/or procedures which are similar in terms of care delivered and the resource used. In order to reflect the complexity of care delivered, HRGs capture main condition treated, investigated, procedures, investigations performed, comorbidities, complications, age, length of stay. Healthcare resource groups offer organisations the ability to understand their activity in terms of the type of patients they care for and the treatments they undertake. Why is clinical coding so important? Clinical coding provides the information that underpins almost all the data flows within the hospital. It can be used for clinical governance, quality improvement, epidemiology, benchmarking, commissioning, financial flows. The challenge. Coders are only able to use information that has been documented in the clinical notes. Incomplete or unclear documentation has been repeatedly shown as a weak link in the data quality chain. Now we know how important accurate clinical coding is to NHS organisations. Here are some top coding tips. Clear. Write clearly and legibly, type if possible. Use appropriate language. Check with your organisation, as some have agreements to accept certain terms. Complete. Ensure all diagnoses and procedures are recorded in detail. Document all relevant comorbidities. Understandable. Abbreviations and shorthand cannot be coded. Coders are not allowed to interpret investigations or numbers. Accessible. Make sure the coding team know where key information is recorded.
Okay. So, the basics of that, hopefully you understood that bit of that animation. But essentially, the key points in it are that whilst coding is not used directly for payment anymore, in the payment PBR national tariff system, it is still a capture of activity. So it's really important in negotiations, and rather than it being on a monthly or every quarter assessment, it's on an annual assessment. So it's really useful to make sure, it's really important to make sure your coding is accurate. That's the first thing to say. The second to say is that coding applies to inpatient stays and outpatient. So inpatient, day case, outpatient kind of is what's coded. So the next thing I thought I'd talk about is some of the issues we faced and some of the things that we're trying to, some successfully, some less successfully, trying to put into place in our hospital. So the first thing that we've noticed is that not all our activity was being captured. So our activities, basically, you can only notice that somebody's coming to hospital if they have an appointment or they're documented on a computer system somewhere. So the coders need to know that a spell has been generated. And what we found was there were numerous wards, plastics clinics, there were various places where patients were coming for reassessments or wound reviews or all kinds of different things. Some of them even had minor procedures going on, but it was just a list of patients on the ward. The ward had a clipboard. They had some, a list of patients, and they were coming in, being seen on the ward, and being discharged home. Great opportunity, great kind of process. Didn't require them to be admitted or anything like that, but it wasn't being recorded anywhere, which meant that the episodes weren't being coded, which meant our activity data didn't look as good. So it's important to make sure that all your activity is captured somewhere. So it has to be on whatever your patient record system is. So we use Patient Center as our kind of key demographics and spell generation software. But it needs to be somewhere where the spell or the attendance has been recorded somewhere electronically. So that's the first thing. And then the other thing is the next steps all depend on to what degree your trust, your organization uses electronic information. So, for example, if you are a paper-based system, use paper notes or use electronic notes, and what is it that your coders use to code from? So we used to be paper-based, so our coders coded directly from the coded notes. And then when COVID hit, we all our coders ended up coding from the electronic record, which initially was okay because our activity levels were so low that they could take their time and go through the multiple different electronic sources of records that there were. But we've noticed over time, as activities increased again, and also during COVID, we did a lot of work on our electronic systems. A lot of the handovers were electronic because of, and a lot of it was COVID related. So we didn't actually do that much other work. But now that we're coming back to a more usual business, we are unusual. We're in this kind of hybrid situation where we do have electronic systems, and a lot of our documentation is electronic, but we still have paper records. And so because we're often duplicating the work, our documentations, the stuff we put on electronically is often shorthand, abbreviation, shorthand, which, because we're writing it out properly in the notes, but on occasion, and but on shorthand on our electronic records, and the coders can't code shorthand and abbreviations. That's a big area that we're trying to tackle. We're trying to introduce kind of standardized terminology, and talk about that in a bit, to try and at least make it easier for our clinicians who are doing the data entry to make sure it doesn't take them any longer to write formal longhand documentation. So activity, making sure that activity was captured, making sure that we're getting it from the right source. And then the other thing that we are noticing is that so comorbidities can only be coded if they're documented in the current episode, in the current spell. They have to be documented for them to be coded. We are notoriously bad at that. As clinicians, we found that there were lots of conditions, chronic conditions that patients had that weren't often not being documented, or patients were coming back repeatedly. So, for example, a chemotherapy patient may be coming back repeatedly, and rather than, obviously, the clinicians weren't writing out all the various comorbidities each time. So initially we found a loophole in the system where we had a program that could highlight or alert coders to chronic conditions that were always going to be chronic and always going to be existent in the patient, and that we passed some sort of agreement that was signed off at board level, where if there was a certain list of conditions that could be automatically be carried forward. Now that that loophole was closed by NHS Digital and NHS England probably last year, early last year, or maybe even the year before, and so we can't do that anymore. So now we're having to do that at the clinical side, on the clinical software systems. So now that we have access to our GP records, and we can alert the clinicians to encourage them to document any comorbidities that haven't been missed, and they can be carried forward through the clinical system rather than through the coding system. So it's just trying to find ways to making things easier. It's probably the why didn't you stop the committees? Because the coders have to kind of stick with various rules, and one of the rules is that they have the comorbidities that are documented have to be relevant, and so they have to be documented each time, essentially. And we came up with a list of comorbidities that were once a patient had them, they were always going to have them, and it wasn't one of those ones where things like you grow out of, like asthma, you can grow out of, and you can. So these were chronic conditions that were going to be lifelong, but in order to stop gaming of the system, I think it was. Whilst we had a very limited list, what I guess the rules were that they didn't want anybody gaming the system. Is probably the ultimate reason. The coders are very strictly managed and audited, and they can only code within strict criteria. So they're not allowed to interpret things. They're not allowed to. They can clarify things, but probably 95% of the time, you won't. I mean, you won't. They can. They should go back to the clinicians involved and ask them, is this relevant? Is this important? We've noticed this. Can you clarify? Can you confirm that these are relevant comorbidities? But because of lack of engagement, particularly on the clinical side, that hasn't happened. So that's probably why. Yeah, I don't know the ins and outs of it, the rules of the coding world, but that was stopped. That was a loophole that was stopped last year, and our coding numbers are plummeted. Our depth of coding, which is our measure of how many comorbidities and conditions are coded for each episode, suddenly went down, and we look at it quite closely and to see what can be done to alleviate that. And unfortunately, a lot of our issues are related to our kind of hybrid working with both paper notes and electronic records. Other things that are important to note is not all comorbidities are equal, and they have different impacts. So, apart from funding, they impact things like the hospital mortality ratios, of observed and expected deaths, so the key ones that you need to make sure you highlight are what's called the Charleston index, and these are the Charleston kind of key comorbidities that we need to highlight. And the scoring system is what's there in this Charleston index. But they carry quite a lot to weight for your HSMR, which is your hospital standardized mortality ratio. So it's important they get captured in your first or second FCE. So those are the key ones there. One of the things that we've kind of found or issues with are something called Z codes, and Z codes are things that affect a patient's stay that are probably more social related. So things like patient lives alone, is wheelchair dependent, or walks with a walker, or there are a whole list of them. They're called Z codes. And they impact a patient's stay because they can often delay discharge because of they won't fit the criteria for daycare surgery if they live alone or don't have somebody to stay with them, and all that kind of stuff. So they're quite important in that respect, but they're not often very well documented. So we found they were being documented in different parts of the notes, which the coders weren't coding from, or the therapies. So our allied healthcare professionals were documenting them, but they used a completely different system. And one of the key things that we found was that our coders weren't using this other system that our allied healthcare professionals were using, and so our therapies data wasn't being coded at all. And overall, that I said that led to a shortfall. I say a shortfall, a theoretical shortfall of about £10 million. Now, it's a theoretical shortfall because they didn't have the money to replace, the CCG don't have £10 million just to pass on to us. Yes, yeah, factors influencing health status and contact with health services. So there is a load of codes in there that we often miss for clinicians when they're documenting stuff, but the therapies teams always get them, but we need to make sure that they're documented and deemed to be relevant. That's the other thing, they need to be deemed to be relevant to the patient stay. So yes, so making sure your therapy data is coded, making sure your Z codes are coded are two of the big things. So there's something called R codes. Now R codes are signs and symptoms codes. They are they're more vague. So chest pain is a non-specific chest pain is an R code. They tend to attract a lower tariff if you're talking from a financial point of view, but also they have a lower mortality index. They have a they in terms of your activity data, it's less accurate, it's less precise, so it tends not to do as well. And so you try and avoid having R codes in your coded data. But there are some R codes, and I'll come on to this when we're talking about same-day emergency care, that it's less important for, because there are loads of patients who come in to A&E or to CDUs who come in for chest pain, and you don't really have a diagnosis. You just have it's not a heart attack, it's not cardiac, therefore they can go home type thing. And it's important to kind of try and exclude those out of your main inpatient R codes. I mean, there are some areas where there's a high percentage of R codes in the system, but overall you want to try and limit the number of R codes. Consultant episodes and mortality. Here we go. So HSMR is based on your first 2 FCEs. So your FCE, each consultant episode is made each spell is made up of multiple consultant episodes. Potentially it can only be one. We had an issue where we have a CDU where you often have if a patient comes in at 7, they're deemed they're under one consultant, then there's another consultant that works from 8 till 12 or 8 till 1, and another consultant from 1 till 5, another consultant from 5 till overnight. Okay. And the way our system was being documented for the purposes of making sure that any test orders went back to the appropriate consultant to review and acting on results and investigations, that kind of patient safety aspect meant that every time there was a changeover in consultants, that patient went under a different consultant, and that meant a new FC was being generated. Each FCE was about 4 hours long, but each a new FC was being generated. Now, for HSMR purposes, so mortality purposes, it is based on the first 2 FCEs. So if you do not have, if either the comorbidities aren't documented, or you don't have a decent diagnosis in your first 2 FCEs, then that can cause a massive impact on your HSMR, which is an issue potentially under the current system. Now, I'm hoping that when I talk about the same-day emergency care and how that's going to shift how coding works, that may address some of the issues, but we found that was massive impacting our predicted HSMR a little bit. So it's just something to be aware of, that it's the first 2 FCs that are important for HSMR and consultant episodes. The other thing is, when you're looking at your coding and looking for where there may be areas to improve your coding, looking at your PLIX data is always a good way of doing it. So you look at your costing data and you look at where costs are really high or unexpectedly high, particularly for the high volume, low complexity stuff. And if you are finding that hospital standardized mortality ratio, it is one of the mortality markers that are used by as benchmarking standards. As an absolute, it doesn't really make much difference, but as they look at trends. You look at so NHS England looks at trends in hospital mortality, hospital standardized mortality ratios. Where was I? lost my train of thought now. Plex, yeah, look at costing to identify problems in your coding, and that's what we've tried to do, and that's what a lot of places try and do, is that they so Leeds are very good at this kind of stuff, and one of the things they've done is that they look at their Plex data, found that, for example, in cardiology, they did a lot of work in cardiology. Amongst other things, they found, for example, you know, some of their angiograms were costing, angioplasties were costing, taking twice as long and costing like double the amount as a result. And when they looked at it more closely, they found that it wasn't there were you know, anything bad was happening. It's just they were not being coded appropriately. They weren't simple angioplasties. They were, you know, they were using various other bits of equipment and other things that meant it was a more complex procedure.
AUB.
Hello. Okay. So that's one thing you can look at, is looking at your costing data to try and identify areas of code where your coding impact. Right, yes, so the emergency care data set. So in 2017, all emergency care data was recorded in a separate system. So it was using the accident emergency data set, which was from the 60s or 70s, but that was felt to be really old and really inaccurate. So they started to use this new thing called the emergency care data set. And what it's used for is emergency and urgent care. And at the moment, that's it. But over time, over the next year or so, a year or a couple of years, same day emergency care is going to be added into that data set. So that's where a lot of the CDU work, these kind of SAU work, these surgical assessment units, medical assessment units, clinical decisions, whatever your same day units are called, where people come in and have they don't stay, they stay for a few hours, get assessed, and then discharged home. And even potentially maternity assessment units can be they'll be absorbed into the emergency care data set rather than the formal clinical coding process. And it means you can get a slightly different level of documentation and data. Now, there are 107 fields currently in the emergency care data set. Most of them are things like, you know, patient's name, date of birth, address, GPs, how they got to there, all that kind of stuff. But the four main components from a kind of a data point of view are the reason for attendance, the chief complaint, acuity, and diagnosis. And this is entered at the point of the clinical data entry, so it doesn't get often doesn't get entered in subsequently. It's no necessarily review afterwards. But the way they've managed to ensure data quality is they use SNOMED CT. So SNOMED CT, something that's been around for about 15 years. It's a standardized medical terminology. Okay, it's a standardized nomenclature of medical terminology, and there's a UK version of it essentially that the NHS Digital use. And what they've done is they've trimmed it to limit it to 100. I think there's thousands of different SNOMED CT terminologies, but for the emergency fields, they've limited it to 150 or so, so that they can get a decent level of data quality that you're going to see in emergency world. And so this is probably going to be the future. It'll probably help with our clinical coding. It'll take some of the workload away from the simple, small, straightforward, but poorly documented clinical coding areas, such as CDU, MAU, SAU, and it will hopefully then also give us a different way of looking at data, emergency data versus inpatient data. So that's my whistle-stop tour of clinical coding at the moment. as this is especially a workshop, we'll try and any questions at all from you guys about coding. I've deliberately left some time for that. And if there's any questions I don't know detailed answers to, I will get back to you. Yes, Chetan.
Sorry, I was under the impression that proper coding improves the payment from the PCBs or thing. When did this stop? Because I was told it is still going on.
So it does, but not directly anymore. So so the national tariff kind of, well, it still exists. It kind of it was on hold for 2 years during COVID, where we were on block contracts, and then the new contract is a blended system, which takes into account there's two elements to the blended system. There's a fixed element and a variable element. So the fixed element, so what you do is you and your commissioners negotiate, discuss what your planned activity, and you look at your cost data of how much it's going to cost you to deliver that planned activity at ICS level, and your demand, and you kind of come up with a fixed element that's going to cover the most of your fixed costs. Okay. There is still a activity-based payment system in that if you deliver less than that or more than that, it will affect your variable element of your income. So it does, but it's not on a month-by-month basis. At the moment, your kind of income is variable and unpredictable over every few months.
So my question was, if I'm doing a hip replacement in an ASA 1 patient, as opposed to doing a hip replacement in an ASA 3 patient, with a lot of comorbidities, will there be a difference in the payment?
Yes, there will be, but maybe not immediately. So for example, when you do your activity data and your cost data, your organization will look at your data and go, okay, we will probably over the next year, so for 22-23, we will do, and this will vary amongst different negotiations, but you might go, we will do, because you will do let's say 50 hips that are going to be ASA 1s and 50 that are going to be ASA 2s, 50 that will be ASA 3s. Okay, so that's what you're going to predict to do. Okay, and you'll get paid based on that amount. Okay, if for example you do 40 hips of ASA 1s, okay, you'll get a deduction on the tariff on the variable element for those 10 hips that you didn't do of ASA 1s. But if you do 60 hips of the ASA 3s, then you'll get 75% of the tariff for doing those ones. So yes, you will be paid for doing those different, for each HRG group, but it won't be an immediate payment. It will affect, at the moment, or pre-COVID, you got paid based on the data almost on a not on a monthly basis, but every 3 months. They would look back at the last few data and you get paid on that basis. This is more of a longer term, so it would be over the year.
Thank you.
You get paid.
Thank you.
Okay, so it's still really important. It just doesn't have as immediate an impact on your income. Any other questions? So it is. I'm going to keep talking while anybody writes anything or puts their hand up. It is quite difficult to. There are lots of rules with coders. It is important that you kind of have a relationship with coders to make sure that they can ask you questions. We have had a number of. It's been up and down with our coders. No fault of their own, but it's just that they, our ratio of coders, they're working from home, our shift between our activity levels changing, shift between working at home and having to come in, then the whole concept of getting notes and stuff like that has really been difficult during the kind of last couple of years. And our coding data, we were we got to a point just before COVID where we had a really good system coming into place with dedicated leads in each speciality that the coders could go to, but that's kind of fallen by the wayside a little bit because of now they're working from home. There's less communication between people. You don't see people as easily. I'm hoping that going to a more electronic system will help, but we'll have to see. We're trying to address it in different ways, but it's to be honest, the best way of addressing it, and is a way that I want to do but I haven't been able to do yet, is to link coding, PLICs, and quality improvement. If you can link those three areas and address it from that point of view, you can use your coding data and your PLICs data to drive forward quality improvement and pathway changes, and you can often justify your pathway changes that you know would work by using the coded data and the PLICs data to show that it's a cost-efficient way of doing it. Clinicians, it varies, very much varies. There'll be some people who are very enthusiastic about it and have yeah, so it will vary. The things that people don't understand are some of the quirks of the system. So we had, question mark comorbidity, question mark diagnosis can't be coded. There are a whole loads of things that can't be coded, and it's those subtleties. Yes, clinical coding is important, but they don't know necessarily the details of what can and can't be coded. There's also, I mean, I did a mini study in one of the hospitals I worked at when I was a junior doctor, where we got coders to code a set of notes, and we got a clinician to code a set of notes, or highlight the important things in a set of notes, and they come up with different things. What coders think is important, have to code and find it's important is different to what clinicians think is important. So yeah, so there is a lot of variability in it. There was probably probably more of a drive when it was directly linked to finance. Now it's a bit more tenuous, the link to finance and money income. People have come up to me and said, "Oh, why is it important to code properly still? It's not really getting paid anymore." But you are. Even the chief finance officer, chief financer of NHS England, admits that this is still activity based. It's just in a different way. It's just payment system in a different way. It is still an activity based system because of the waiting list backlog. So yeah, it does vary. And it's hard to educate people because you educate the consultants, that's fine, but most of the documentation is done by the juniors, and then you have to keep educating the juniors. And we've had people try and do at the junior doctor inductions, try and go and talk to them about coding, but to be honest, that's probably not the right time when they're just about to start their new organisation. Their focus is on getting parking, getting their working life sorted, making sure they get paid on time. All that kind of stuff is much more in the forefront of their head and their minds than thinking about how to document properly. That's probably something that needs to be done over a period of time by consultants, ideally by their bosses, over a period of time. It can be built into the education program, but it's as important to ensure you document accurately for medical legal reasons. With my medical legal hat on and consent issues, we have poor documentation for multiple reasons, and that's a whole area that needs to be focused on by our juniors, and we need to encourage. Any other questions? You can shout it out if you want. No. Well, I hope you found that vaguely useful. We will send out probably a copy of this transcript or this recording and one by the one of the coders as well, to give you something to compare it to, just so that you get both sides of the equation, I guess, to discuss it in a bit more detail. If nobody else has any questions, I can give you a few minutes to have a break. I don't know if anybody's joining the second set of